Welcome to today's webinar. My name is Jose Francisco, Project Manager at IAS-USA. This webinar is designed for HIV or infectious disease fellows, residents, and practitioners who are new to the field of HIV research and management. I would like to introduce today's speakers, Drs. Michael Saag and Rajesh Gandhi. Welcome.
Thank you. Thanks everybody for being here. Dr. Gandhi and I are very excited about participating in this webinar with you. I have a couple of introductory slides we're going to go through, and then I'll do a presentation on the basic biology of HIV as it relates to antiretroviral therapy, and then Dr. Gandhi will pick it up and talk about how to use commonly available antiretroviral therapy. We'll try to wrap this up certainly before the end of an hour, and then have up to 30 minutes or so around that for questions and answers, so let's get to the basics. The IAS-USA is the sponsor of this activity, and they are accredited by the Council for Continuing Medical Education to provide the CME event. It has 1.25 Category 1 credits, and physicians can claim this commensurate with the activity that they're participating in. We also have nursing credits, again up for 1.25, and pharmacy credits, and I never understood this, but I'm rolling with it, 0.125 CEUs for pharmacists. So that's available for all of you, and we hope you take advantage of that. These webinars are made possible through unrestricted educational grants from the folks you see listed here, the different companies. These grants are made, as I mentioned, in an unrestricted way, which in essence says we like the content, not the content, we like the educational activities. The content is up to you, that is the IAS-USA, and the speakers to put together the, as per ACCME guidelines, all content is reviewed by unbiased reviewers before the activity proceeds. We're going to do a little polling throughout the presentations at different points in time, so we're going to give that a whirl here in just about 25 seconds, so get ready. The poll questions will pop up and you will see them. You can obviously see that this is the right way to do it up here, and you don't go to the chat box. So you'll see the poll and just answer right in there. And then, but if you do have a question, that's what the chat box is for. So hopefully the chat box will be your venue to ask us questions as we get through it. You can write those questions in as the presentation's going on, and we'll get to them after both of us have finished our session. So now we're going to go to the first poll. It's basically, you see it popping up there, isn't that cool? And you just click on the answer that best suits you. Go ahead and vote. Give you a few more seconds here. It looks like we've got good responses going. Okay, let's see what we got. So it looks like we've got folks from all over the country and a few from out of the country. We're pretty much evenly distributed, but mostly it's in southeast and northeast United States, some folks from the southwest. So going to the next, one more question, I think. Yes. How would you rate your level of experience in the medical field of HIV? So if you're just getting into this, you'd put that as a 1, and if you've done this a whole lot for a whole long time, then you can put 5 and obviously points in between. A few more seconds. Okay, let's see what we got. And as this meeting is designed, we are looking at folks, about 31%, who are really just entering the field. So I think between the answers 1 and 2, at least half the audiences are relatively new to the field. And if you've done this for a while, you're certainly welcome to be here. Happy to have you. And we're going to go through this, the talks right now. So I've got the first half. Dr. Gandhi has the second half, and I'm going to dig right into this. So the objectives are to summarize the events of early HIV infection, to list the sequence of laboratory markers following HIV acquisition, the basic mechanisms of how antiretroviral therapy works, and then how to select therapy for those who are starting initial therapy, who have persistently low viremia, or pregnant or considering pregnancy, and those who are experiencing virologic failure, and especially if they've got resistant virus. So we're going to do all that in the next 50 to 60 minutes or so. So here's the first poll question. This is from me. So at steady state, when an actively producing cell dies, it's replaced by how many newly infected cells? Give you a second to think about that. So what I'm asking is that when viral load is steady, somebody's already been infected, a cell dies off, it's replaced by how many cells when it's at steady state? People are thinking about that a little bit. I'll give you about 4 seconds more. All right, let's see what we got. All right, I predicted that 25% would pick answer 5, and it's actually 41%, so more than I thought. The correct answer is 1. Answer 1, number 1, and I'm going to go through why that is. And you'll see as we go through why the viral load is not dependent at steady state, and that they are separate things. There is a relationship between viral load and the number of cells infected in the body. We're going to talk about that. But at steady state, when one cell dies, it's replaced by precisely one cell, and that's a really critical concept of antiretroviral therapy. So here's another question. It's a pretest question. A woman who's in her second trimester in her 30s of pregnancy is diagnosed with HIV. Which of the following antiretroviral medications should not be prescribed? You've got 5 answers here. And I'm going to let Dr. Gandhi give you the answer when he gives his presentation. Okay. Let's see where we are. Here come the results. And it looks like answer 3 was the most popular, although pretty good test question because everybody got a little bit of activity. And again, I'll let Dr. Gandhi go through that when he gets to his section. So here we go. Going into my talk, again, we're going to talk about principles. So let's go back to basics. Here's a cell, and that cell gets infected with the virus, and the virus enters into the cell and binds and enters through a CD4 receptor and uses either a CCR5 or a CXCR4 co-receptor to enter the cell. Once it comes in, or in the process of coming in, the RNA of the virus is converted to double-stranded DNA through a process called reverse transcription. And that it means that you're converting RNA to DNA. And remember, normally when a cell is producing ultimately proteins, it's taking the host DNA, going to RNA, usually in the form of messenger RNA, and then it gets transcribed into proteins, or translated. This is transcription going in the opposite direction, and that enzyme called reverse transcriptase is critical for that activity, and that's why these are called retroviruses, because they, in essence, go backwards. They go from RNA to DNA instead of the usual way. Once the virus becomes double-stranded DNA, it comes into the nucleus of the cell, and it integrates into the host DNA, and that's why when a cell replicates, it's carrying that, an infected cell will carry that virus with it every time it replicates, and that's really our barrier to cure. Because if the virus just had stayed in the cytoplasm like hepatitis C does, we could cure HIV. But right now we're struggling because it's integrated, and we have to find a way to get rid of this entirely infected cell to the point where there's no more infected cells left, and we haven't been able to do that yet. Once it's integrated, it'll produce both structural proteins of the virus as well as the envelope protein, and then create also another copy of itself to come to the surface of the cell, begin to form a new virion, and it gets released. And as it gets released, it's still undergoing maturation. So the maturation of these viral particles really depends on something called a protease. And that protease is an enzyme that basically cleaves proteins. So you get a big long string of spaghetti, and the enzyme comes in and cuts, just like going from proinsulin to insulin. It cuts, and you end up with functional strands of protein, and that's precisely what protease does. Why did I go through that? Well, I think it's pretty clear that any one of these steps, binding, entry, reverse transcription, integration, and maturation through protease inhibition, are all of the ways that we create drugs. So you'll hear a lot about those drugs, and they're categorized by their particular activity with the viral life cycle. So Dr. Gandhi will be talking about entry inhibitors perhaps, but for sure reverse transcriptase inhibitors, integration, and protease inhibitors. When you give therapy, this is a study that we did back in 1992 or 3, and we gave a very potent drug. In this case, it was a protease inhibitor called Indinavir, and we saw viral load drop precipitously in the matter of 2 to 3 weeks. And working with some really smart people, most notably a modeler named Martin Novak, we were able to make a lot of estimations just from this one curve. We could determine that the half-life of the virus inside the body was about 1 day. So once it was produced, it went away in about a day. And so we also were able to deduce exactly what antiretroviral therapy does. But before I get to that, I'm going to ask that question. I already gave you the answer. See if you were listening. How many new virions are produced in a day? Now, I didn't exactly give you the answer, but if you had a calculator and could do calculus real fast, you could figure it out from a 1-day process. But Martin was able to help us. Now I'll let you vote. How many virions are produced a day in the entire body of a person who's infected? A lot of answers still coming in, so looks like a few more seconds. All right, let's go ahead and post the results. The answer is over 1 billion. Over 1 billion viruses are produced a day. It's really estimated between 1 billion and 10 billion viruses a day. That's pretty freaky when you think about it. That's an awful lot of virus coming from infected cells in the body. And if you compare it to hepatitis C, there's 100 billion to 1 trillion viruses a day. It almost makes me want to do a Dr. Evil impression and say something like 1 billion viruses. Well, that's exactly right. So a lot of viruses produced every day. And this was published in Nature in January 1995. And here again you can see Martin Novak's name, who I credit with really a lot of the ingenuity of that paper. And it really, I think, was important because this is exactly what it showed. And if I could just get you to focus up here first, just out of this one graph that I've already shown you, this is the life cycle of how infected cells go. So you start with an HIV-infected cells that produce viruses. And those viruses, as I already mentioned, about 1 to 10 billion viruses a day from the pool of infected cells. And those viruses come down and they infect these uninfected, activated CD4 lymphocytes, so in blue here. The yellow cells are the unactivated resting CD4 lymphocytes, and they make up the overwhelming majority of cells in the body, T cells, that are not really that susceptible to infection. It's really only the activated CD4 cells that are the cannon fodder for the virus. And as I've already told you, once the virus comes out, it infects these cells and comes back up here, and that life cycle is about a day on average. So these cells get infected, they produce a lot of virus. We don't know the exact what we call burst size, that is the amount of virus that comes from a single cell during the lifespan of its infection, but it's probably on the order of several thousand to maybe up to 1 million viruses a day, depending on the setup, but there's a lot of virus produced per infected cell. And this cycle just continues every day. And that churning starts from day one and continues on every day that somebody's infected. When you give antiretroviral therapy, what you're doing is you're blocking an uninfected cell from becoming infected. That's all it does. It has no impact whatsoever on these cells up here. It only affects protecting these guys. So basically, this decay that we see in the graph is simply, now that we've stopped replacement of the cells with infection, this is basically the decay rate of these cells dying off. And so that's where they come up with the one cell lives for about, one cell lives about a day. And then most, again, 99% of the cells here will die off in about a day or two, but there is a long-lived, latently activated CD4 cell that really isn't producing virus very much, but it's sort of hanging out there, and it is the reason that we can't cure HIV. As long as we have this antiretroviral therapy on board, these guys may spit out virus every now and then, especially if they get stimulated, but with antiretroviral therapy on board, this is still protected. If you took this antiretroviral therapy away, these cells spitting out virus now could have a pathway to, again, infect these susceptible activated CD4 cells, and you can reignite the fire, in other words, by this process. So that's the reason why if we stop antiretroviral therapy, within 2 to 3 weeks on average, it could be longer, not usually that much shorter, you'll see the viral load become detectable again, and that's a sign that this virus is now taken over. And what's remarkable to me is that the actual number of virus particles, the viral load, is remarkably consistent over time. So you have, let's say the viral load at baseline is 30,000. You give antiretroviral therapy over a period of several weeks to a couple months, it drops to undetectable. If you stop the antiretroviral therapy, then over a period of a couple weeks, that infection reignites and the viral load comes back up, and remarkably, it stays right at about that same set point, about 30,000. For another patient, it might be 100,000 or 2,000 or 1,000,000, but that set point is unique to each individual, and it's really based on how susceptible the cells might be, but it's mostly about how efficient the body is at clearing these infected cells, and we'll get to that in just a minute. But this, to me, is a critical concept, because it explains a lot of what you've already probably learned, and that is if you give therapy, the viral load goes down and stays down, you keep it on board, you take the viral therapy away, and the virus comes back. This was a really interesting study, again, that we had done right after the study that I just showed you, where we basically took patients before and about 4 to 6 months after therapy and looked at their viral load, but we did lymph node biopsies before and after therapy. And these were usually taken from cervical lymph nodes or from axillary lymph nodes. And then we looked inside the lymph nodes and determined how many cells per million were producing virus by in situ hybridization and a couple other techniques. The takeaway point here is look at this. Look at the linearity. I mean, you don't need to be a statistician to say there's a relationship between the number of cells in the body that are actively infected and producing virus and the viral load, right? It's crystal clear. And what that told us was that that relationship of the number of cells in the body being directly proportional to the viral load sets up that concept that as you protect cells from becoming infected, the infected cells die off and the viral load drops. That one-to-one relationship. And if we take that back to the concept I asked earlier about steady state, when we're at 30,000 copies and those cells are being replaced every day, they get infected, they live for about a day, they spit out virus, and then they die. Isn't it remarkable that that cell, when it dies, is replaced by precisely one cell to keep the viral load steady, because otherwise you would get fluctuations in a big way with the viral load, and we don't see that. Well, let's take this to another conceptual level. And I've already asked this, so I guess I'll ask it again real quickly. When an infected cell dies at steady state, how many is replaced? And it looks like you guys can be taught. I'm watching the results come in. This is fascinating. So, yeah, good. Let's go ahead and post the results. So look at that. Look at that. So yes, most everybody got it right. And it doesn't depend on the viral load. It depends on, it's simply a matter of steady state physics. If you go back to high school or college when you studied physics, steady state means it's the same. And since we know the number of cells in the body that's producing virus is directly related to viral load, when it dies, if the viral load stays constant, it by definition is replaced by one. So great. That's a wonderful concept. So let's move on to a conceptual model now. I know, this looks like a kidney, but it's really a lymph node. These are the germinal centers. But in the parafollicular region, inside lymph nodes, that's where the T cells live for the most part. And in this model, I use the same color scheme. Majority of these cells are unactivated CD4 cells, and there may be a few activated ones, and some of these are actually infected. So to take it a step further, inside this lymph node, if we say that the viral load is about 100,000, it's not too hard to find those cells. They're throughout the paracortical region. But if the viral load now drops to 50, it's like, where's Waldo? You got to look around pretty hard, and then, oh, well, I guess that's one over here. But you get the picture. Viral load is directly proportional to the number of cells in the body producing virus. Well, let's dig even a little bit deeper, and now we'll begin to understand how antiretroviral therapy works on a molecular level. So this is, in my mind's eye, what the microenvironment looks like. We've got an infected CD4 cell in here that, say, got infected about an hour ago, and it's going to churn out and put out these little viral particles. And those particles ultimately get released from the lymph node, and they go into the circulation where you can detect them, assuming there's enough cells in the body producing. And notice in that microenvironment, there's a number of cells, but most of them are unactivated CD4 cells, so they're really not permissive for infection. So this guy is basically firing a lot of blanks, just sending out its vibe, and nobody's really kind of grooving on it, right? Nobody's really locking in. So this is going on for about a day. And during that 24-hour period, all of a sudden, here comes an activated cell into the environment. I often think about this like as Night at the Roxbury. You remember with Chris Kattan and Will Ferrell, and they're being obnoxious and trying to hit on somebody, and nobody really wants to play. That's the people who are kind of normal are here. But here comes, let's say, a drunk person who they're trying to hit on. They're activated CD4 cell. The virus comes up, it binds and enters into that cell, infects it, right about the time that that guy dies at steady state. That's what's happening every day in every patient before they get on antiretroviral therapy, this constant churning of infected cells infecting another within a 24-hour period. The primary cell dies, it's replaced by another, and so the cycle continues until we give antiretroviral therapy. And what that does in essence is it puts a force field around this, or maybe if you want to go to the Night of the Roxbury and be really silly, that's a condom. So somehow this cell is now protected from infection by this guy. So at the time this guy's lifespan is over and it dies out, it's not replaced by a newly infected cell, and whoosh, viral load drops. And that will continue for as long as we continue antiretroviral therapy. And we know now with years of experience, constant adherence to therapy will keep the viral load sustained. Every now and then we have blips, right, where you see some virus coming out, and that could be just taking it a step further, if this cell didn't die and it's one of the long-lived ones, it's not going to produce nearly as much virus. But every now and then it might get stimulated and kick out enough virus where you can detect it. Say somebody gets sick or the immune system gets stimulated, it can fire off some virus that you can detect, and you see it with the viral load going from 20 copies to maybe 50 or even 100, but then it'll come right back down to an undetectable level, and that's what we see clinically. As long as the antiretroviral therapy remains constant, these uninfected cells will no longer become infected, and that's how antiretroviral therapy works. And to me, every time I'm treating a patient, every time I'm interacting in this kind of way, in my head, I'm thinking of these principles, and it helps me understand what's going on as I treat. So all that remarkably, everything I just told you, with the exception of the one-to-one relationship, came from this graph. Isn't that cool? I think that's just an amazing story. So what happens if we don't give adequate therapy? So this reminds me of the days in the past where we had, say, we used monotherapy of nevirapine, which is a non-nucleoside agent we don't use hardly anymore, but it's a non-nuke, and it had a very low barrier to resistance. All it took is one mutation, and you could get resistance to that drug. And it could have been a position 181, or it could have been a position 190 in reverse transcription. So what happens here? If we gave nevirapine monotherapy, just that drug by itself, we had pretty good protection of this uninfected cell, except if in the course of producing these tens of thousands of viruses, we know that every time the virus replicates, reverse transcription is not terribly, it doesn't have high fidelity, so it can make a mistake. And if it just happens by chance that it makes a mistake at position 181, and you go from Y to C in terms of the protein, so you get a Y181C, and then that virus starts to get produced by chance, that means nevirapine is no longer active, and that virus will sneak in the door in this picket fence or whatever, and it will infect that cell. And then from that point forward, as this initial cell dies off, the new cell that's infected, almost all the viruses it's producing has Y181C in it. And so rapidly, you can develop resistance. I'll tell you how fast it is. You can start seeing virus in the bloodstream on nevirapine monotherapy within a couple days. You see half of the viral population with nevirapine monotherapy by day 14. And then by day 28, almost 100% of the viral population has the resistant virus in it. That's how fast. Why is that? Because the replication is so fast. We've already talked about it. Cells live on order of a day, produces about 1 billion to 2 billion copies, maybe 10 billion, and this turns, and then you get that resistant virus in there, and it just gets amplified like crazy. So that's how that's working. Again, this is what we want to do. So when should it be started? This is my entry and my segue over to Raj. Generally speaking, nowadays we are looking at any CD4 count, and there are a few exceptions to that, and mostly it's in the situation of a elite controller, but we can talk about that. I'll let you all answer. Sorry. Yeah, I just gave you the answer, but it's okay. I think you all pretty much knew that. So yeah, let's go ahead and post the result. So we're back in the day, we had talked about, well, I'll just tell the history quickly, and then I'll hand this off to Raj because I'm at about 30 minutes now. But the history of this is that when AZT was our first drug, they weren't sure it was going to kill people. So the entry criteria for getting into that study was prior pneumocystis pneumonia or a CD4 count less than 200, because they wanted people with advanced disease. And that sort of started us on this path of CD4 count somehow being the marker, the metric that said this is when you should start therapy. As in the 90s, as we got, I think, more sophisticated in our understanding of the viral pathogenesis, like I just shared with you, a lot of us were kind of screaming from the rafters, why are we relying on CD4 counts, for goodness sakes? This is a virus producing 1 to 10 billion copies a day. How can that be a good thing? Let's shut it down. We don't wait for cancer to get out of control before we start treating, right? We want to catch it early. Same thing here. It took us a while, but now we're at a point where we treat most everybody regardless of CD4 count. And you can just see that other complications of therapies are that our patients often have more comorbidities, and we're going to have to deal with that clinically as time goes on. And I think you see that, especially as folks get older, and then that leads to things like polypharmacy and a number of other things. One other critical thing is that while treatment, and this study is looking at CD4 activation, here's an HIV uninfected person. You see a lot of activated cells, in this case CD8 cells. When you treat, it comes down nicely, right? Activation decreases because the cell's not churning, but it never quite hits normal, never quite hits the HIV uninfected. And this is why a lot of us are pitching that we should be treating patients with CD4 counts, regardless of CD4 counts, and even those with elite controllers, and that means people that do not have any detectable virus. They're just naturally controlling it, but there is, I'm sure, below the level that we can detect, this churning that's going on. And there may be some residual T cell activation I've already mentioned. I'm going to skip this. It just basically says that deferring antiretroviral therapy is associated with bad results, and we have some pretty good data on that now. The final thing is that we have to pay a lot of attention to cost of therapy, and treating earlier also has been shown to be cost effective in terms of long-term events. And for anybody who wants to argue with you about, well, starting CD4 count at 650 versus 500, it can take up to 5 years for that person to progress. Let's say you have a 30-year-old and you have 650, you start here, or you wait till they're 35 and you're going to wait till 500. The point of this slide is to say, what the hell's the difference, right? You're going to treat for 40 years to lead to age 70, hopefully they'll live longer, versus 35 years. Is there really a difference here? And the answer, of course, is no. And the question also is, will there be harm there? So we've got lots of evidence that shows that treating earlier is good. Some people are starting to treat very, very early, and like on the day of diagnosis. In sub-Saharan Africa, that becomes very important because there can be huge distances for people to travel to get back and forth to clinic. I don't think we're seeing it quite as much in the United States, but I think it does take an awful lot of effort, and the experience in Atlanta was that, yeah, they could show a little bit of improvement, but it cost them a lot in terms of human capital. And there are a lot of drugs that have been improved, and this is the crazy long list of them. And I think you can see that we made a lot of progress, and Dr. Gandhi will talk about that. I will make this my final slide, and this is looking at something we call a discordant response. So sometimes we see this. This is where normally when we treat in the green, you'll see the viral load drops towards undetectable levels and almost approaches that within 6 weeks. And usually the CD4 count goes up nicely in the upper part of the panel, where you can see it now about 200 cells above baseline by 6 weeks. In the dotted yellow line, and I've lost my pointer here, but it's okay. In the dotted yellow line, you see there's some people who just don't have that. Oh, thanks, it's back. Who don't have that, and that's the dotted yellow line here. And if you look carefully, what they're really missing is that initial burst in the first 6 weeks. See how the green line went up about 150 to 200 cells within 6 weeks, and The yellow line didn't. And if you look carefully out towards 2 years or so, the slope of the increase between the two groups is about the same. So really what we're saying is those people who get treated, they have a CD4 count of 34, and 2 months later the CD4 count's only about 70, and we have cases like that. What that really means is they did not get that redistribution of cells. Cells are trapped inside lymphatic tissue. When you treat, the inflammation that's associated with that ongoing replication gets suppressed, and the cells re-release back into circulation, leading to that increase that we see. And the reason why you don't get that probably is that during the course of a long battle with HIV before they got diagnosed and treated, they've destroyed they had a lot of loss of lymphoid architecture, so those cells are not there just to be repopulated. And that's why you see that. And changing antiretroviral therapy simply because you're not seeing a CD4 count increase is not going to change that biology. The viral load's still suppressed, the drugs are still working, and you're good. So conclusions, understanding the life cycle is very important, understanding this. Viral dynamics are dynamic, and therapy interrupts retroviral replication, completely halting most of the damage done by HIV. HR protects uninfected cells from becoming infected, and that the antiretroviral drugs target specific things within the life cycle. And then Dr. Gandhi, I'm going to turn it over to him right now, and he's going to take us through how these drugs work in the real world. Raj.
Great. Thank you, Dr. Saag. I'm going to pick up where we just left off, and I'm going to go through some of the applications of antiretroviral therapy, and I'll present a framework for how I think about a newly diagnosed person with HIV. So let's go through that now. And I'll contextualize this in the setting of a case. This is a person I saw not too long ago, a 45-year-old man who has sex with men. He's tested for HIV as part of a life insurance evaluation, and his fourth-generation antigen antibody and confirmatory tests are both positive, and he's had no prior HIV testing. And so when I met him, he asked me a couple of questions. He asked, when should I start therapy for HIV? We heard a little bit about that, and we'll go into some more detail. What should I be treated with? And so we'll delve into the specifics of the drugs, and how will we know if the medicines are working? So before we get to those questions, let's talk a little bit about how to approach a person newly diagnosed with HIV. And I like to break it up into 3 steps. The first is what to focus on the history, the examination, and laboratory testing. The second is to contemplate whether or not they need opportunistic infection prophylaxis. And then the third, of course, is antiretroviral therapy, when and what to start, and how to monitor. So starting with the history, a couple of things that I'd like to focus everyone's attention on. One is the risk behaviors and approximate date of infection. So the risk behaviors matter not so much of why people get HIV, but some of the comorbidities and co-infections that come along with that. We know that men who have sex with men are more likely to acquire HHV-8, that's a herpes virus, and that puts them at risk, for example, for Kaposi sarcoma in a way that is greater than for women, and also greater than for people who acquire HIV through injection drug use. Date of infection, we heard a really nice summary of the dynamics of HIV. It takes usually about 8 to 9 years between someone acquiring HIV and developing a CD4 count of less than 200, developing AIDS, but that varies quite a bit, as we heard, depending on the viral load. Exposures, have they had exposures to tuberculosis, endemic fungi, sexually transmitted infections? These first 2 are things that can reactivate in the setting of a low immune system. What medications are they on, including alternative medicines, and have they disclosed to friends or family? The things that I focus in on the exam, I'll show you some pictures of some of the cutaneous or skin findings. If they have a CD4 count of less than 50, they're at risk for cytomegalovirus retinitis. I usually will refer them to an ophthalmologist because that is a feared complication of a low CD4 count. I'll show you some oropharyngeal findings. Lymphadenopathy is very, very common in untreated HIV. It's usually symmetric, diffuse. If there's a dominant lymph node, or if the lymph nodes enlarge dramatically after starting therapy, that's when I consider sending for a biopsy. If it's diffuse, symmetric adenopathy, I usually wait until the viral load is suppressed and see if the adenopathy resolves. As we heard, A lot of the action in HIV is in the lymph nodes, and so that can be manifest as lymphadenopathy. In women, I'll do a cervical pap, and in men and women, I'll do a rectal exam looking for anal masses and then anal cytology. Happy to talk about that in the discussion. As promised, here are a couple of pictures. Prurigo nodularis, let me turn on my, is right here. That's kind of areas of subcutaneous, sometimes hyperpigmented nodules in areas of excoriation. That can be a manifestation of the pruritus that people with uncontrolled HIV get. This is a classic picture of Kaposi sarcoma with the purplish plaques, sometimes on the face and other cosmetically disturbing areas. Aphthous ulcers are these kind of shallow ulcers. They can be in the mouth, they're posterior oropharynx, but they can also be in the esophagus and other parts of the GI tract. And then oral candidiasis, so-called thrush. Thrush usually is this kind of whitish plaques that will come off with the tongue blade, but oral candidiasis can also just present with oral erythema or with angular cheilitis, that is kind of fissuring at the corners of the mouth. So those are a couple of different ways that your patients might manifest oral candidiasis. Here's the routine laboratory evaluation. I'll do chemistries, BUN, and creatinine in people with newly diagnosed HIV. I'll do a CBC and DIF, fasting lipids and glucose. And then some of our drugs that we use can affect, cause anemia if a person is G6PD deficient. So I'll check that in African Americans as well as males from certain parts of the world, such as the Mediterranean, India, and Southeast Asia. And then I'll do a urine analysis. Here are the laboratory tests where we screen for infection, co-infections really. CMV should be done if someone is at low risk so that counseling can be provided if a test is negative. Happy to talk about that in the discussion. Toxoplasma, IgG, and then a tuberculin skin test, or TST, or an interferon gamma release assay should be done. Remember, for people with HIV, a positive skin test is more than 5 millimeters in duration. And an important point to always keep in mind is if your patient is negative and their CD4 count is less than 200, make sure to repeat that tuberculin skin test or IGRA after immune reconstitution. STI screening, syphilis, gonorrhea, chlamydia, I usually do it annually, every 3 to 6 months if there are exposures, and do 3-site screening, urethra, rectal, and oral in men who have sex with men. And then hepatitis A, B, and C serologies is also part of your initial workup. One word about hepatitis C screening. So hepatitis C antibodies should be done at care initiation and then annually for people who are at risk, for example, men who have sex with men or people who inject drugs. As I think all of you have probably seen, there are increasing rates of sexual transmission of hepatitis C in people with HIV who are also MSM. So it's well worth keeping that on your list of things to screen for. The other point to remember about hep C is it can take a few months, actually, before the antibody test becomes positive. And in that earlier setting, supposing someone has a recent exposure to hepatitis C, that's where the hepatitis C RNA is most useful to diagnose acute hep C. That window period for hep C can be up to 60 days. Now let's delve into the HIV-specific tests. The CD4 cell count continues to be the best predictor of a risk of opportunistic infections or certain opportunistic cancers. This is kind of showing you from a paper from the 1980s that pneumocystis usually occurs with a CD4 count of less than 200, and Mycobacterium avium usually occurs with a CD4 count of less than 50. And then you see a broad distribution of other opportunistic infections depending on the CD4 count. I'll pull up my pointer again, and so you can see a variety of opportunistic conditions occur below a CD4 count of less than 200. That's why the CD4 count is generally used to decide when to start opportunistic infection prophylaxis, and we'll touch on that in just a moment. The HIV RNA, as Dr. Saag showed us, the viral load is the most important predictor of response to therapy. That should decline to undetectable within just a few months of starting antiretroviral. A word about resistance testing. Resistance testing should be done in people who are newly diagnosed, like the patient I'm presenting, or someone who's not yet been on therapy, and there I will do a genotype. A genotype looks for mutations in the viral genes, and the genotype that you want to do in newly diagnosed people is the reverse transcriptase and protease genotypes. If you have a person who has virologic failure to either first or second line of therapy, you should again do a genotype, but here's where you want to do the integrase genotype if they're failing an integrase inhibitor, and we'll talk about integrase inhibitors momentarily. In someone who has very complicated resistance, or you think they might have complicated resistance, that's where you can consider augmenting the genotype, where you're looking for mutations, with what's called a phenotype, which looks at the characteristics of the growth of the virus in relationship to different drugs. Two websites I would highly recommend if you're doing genotyping or phenotyping. The IAS-USA has a really nice list of drug resistance mutations. That's the link there. And then Stanford University has a really incredible HIV drug resistance interpretation site that is also listed there. Okay, so now you've done your history, you've done your examination, you've done the basic laboratories. One quick comment about OI prophylaxis. So let's fill in some details about our patient, and that'll inform our decisions around OI prophylaxis. So he's 45, as I mentioned. He's got newly diagnosed HIV. His past medical history includes gastroesophageal reflux disease, allergic rhinitis, hypertension, smoking, elevated lipids, a lot of cardiovascular disease risk factors here. He's on omeprazole and fluticasone. That's relevant to some of the meds we might use. He already had some chronic renal insufficiency. His estimated GFR is a little under 50. It's 48. He's got a CD4 count that's preserved. It's 550, and his viral load is 650,000. Okay, so a pretty high viral load. The average viral load in people with untreated HIV is about 30,000. He's in the probably the top 20% viral load of over 500,000. You do that genotype, and he's got no resistance mutations. You do a surface antigen for hepatitis B, and you find it to be negative. Okay, so this is one slide on OI prophylaxis from the Department of Health and Human Services guidelines. Pneumocystis prophylaxis is indicated if the CD4 count is less than 200, or if the CD4 percentage is less than 14, or if someone has thrush. Okay, oral candidiasis tells you that your patient has functional immunodeficiency, and that's another indication for PCP prophylaxis. I like to give trimsulfa 1 double strength daily. You'll see in some sources that people can be given it 3 times a week. I think it's just impossible to remember to do anything 3 times a week. If I have to brush my teeth 3 times a week, I would forget, but I can remember something that I do daily, and that's why I usually will do daily trimsulfa. The double strength also picks up some activity against toxoplasma prophylaxis as well. MAC prophylaxis was recommended forever, but recently it's now been no longer routinely recommended as long as you can get someone on antiretroviral therapy quickly, and that's, of course, our goal, as you heard from Dr. Saag. Okay, so now let's get into the main part of the discussion, which is antiretroviral therapy, when and what to start, and how to monitor. So you saw these data to some extent already. These are the results of the START trial. This is the trial that answered the question of when we should start antiretroviral therapy, and as you heard, the punchline of the study is that it should be started regardless of CD4 count. What this trial did is it took people whose CD4 count was over 500 and randomized them to either get immediate ART or to wait until the CD4 count got below 350. What I'll highlight here for you is that the rate of serious events went down by 57% in the group that got immediate ART. The number of AIDS-related events went down by 72%, and the number of non-AIDS-related events went down by 39%. So all of these were significant. Tuberculosis, Kaposi sarcoma, lymphoma, those were the most common AIDS-related events, and all were less frequent in the immediate group. And even cancer, if you conglomerated non-AIDS and AIDS cancers, that was also lower in the immediate group. So antiretroviral therapy prevents cancer as well as does a lot of other good things. What about in someone who has an opportunistic infection? This is an older trial that was published more than 10 years ago. it asks the question, how soon after you have an opportunistic infection should you start ART? This is over 280 people with an acute OI. They were randomized to either start ART within a week or two, that's early, or in those days wait until the wait until 6 weeks after the OI therapy. And what you can see here in the graphic is that the rate of AIDS progression or death was lower in the early ART group. Here's a table that you can have in your references if you'd like that really talks about when to start ART in particular OIs. The point I want to make here is if you have an opportunistic infection for which you don't have a treatment, you don't have an antimicrobial, then ART is part of your treatment for the OI. So an example, cryptosporidiosis, microsporidiosis, progressive multifocal leukoencephalopathy, there are no good treatments for those. Starting antiretroviral therapy is your treatment, and you should start immediately. For some other OIs like PCP, MAC, toxoplasma, start the antimicrobial therapy, and then definitely get your ART on board within a week or two, as soon as you're sure that they're tolerating their OI therapy. For TB, the WHO recommends kind of a graded approach depending on your CD4 count. My own approach is in someone with TB, as soon as I know they're tolerating the TB therapy, maybe a week or so of TB therapy, a week or two, then I will start antiretrovirals. Cryptococcal meningitis, and we can have a discussion here, usually we'll wait about 3 to 4 weeks roughly, because we want to get that antifungal therapy on board and get the crypto titers down, and then come in with antiretroviral therapy. This is an important point I always make. If you have a person in a hospital or has an OI, low CD4 count, you want to get that person on therapy quickly. And you already heard that in some instances you're going to want to do it within a day or two. Okay, so how should we treat this person? This is my interactive question, and when we talk about pregnancy, we'll answer the question that you heard at the beginning. So what are the regimens that you would want to give in this particular man who's got a CD4 count of 550, a viral load that's over 500,000, who's hepatitis B negative? And I'm going to warn you, there's more than one correct answer here, so you should go ahead and vote, and then we'll talk about the options. Looks like the votes are coming in. Good. Looks like a lot of you have voted, and why don't we go ahead and reveal the answer, and we'll have a brief discussion. So it looks like the top two choices were bictegravir TAF FTC and dolutegravir plus TAF FTC. I would agree. I think those are the right two, and probably the ones that make the most sense. Most of you did not vote for dolutegravir 3TC. I'll talk about that. I think you're correct. His viral load is over 500,000, and that's one of the situations where you want to avoid the two-drug therapy, and we'll get into that. And some of the other regimens we'll touch on, but I think the convenience and the high efficacy of options 2 and 3 make those good choices. And I'll say a word about the abacavir regimen, which is also chosen here. Let's see, how do I? Okay, there we go. Okay, so here are the 7 classes of antiretroviral medications. We won't go through all of these. They kind of divide themselves into entry inhibitors, reverse transcriptase inhibitors, either nucleoside RT inhibitors like tenofovir, abacavir, lamivudine, and procydamine, or non-nucleoside RT inhibitors like efavirenz, rilpivirine, or doravirine. Integrase inhibitors are an important class because they really are the mainstay of most of our therapies. And then protease inhibitors. Okay, you saw a version of this already. There are more than 30 options for treatment of HIV in 2020. How do you choose between them? Here's where the guidelines, both the DHHS guidelines and the soon-to-be updated IAS-USA guidelines, help guide us. So I'll put up the DHHS guidelines because they were issued recently. Keep your eye out. The IAS-USA guidelines will likely be coming out soon. But these are the DHHS guidelines. Essentially, most people with HIV, it's reasonable to start with an integrase inhibitor, they're listed here, plus 2 nucleoside RT inhibitors. So many of you voted for this option here, bictegravir TAF FTC. I think that's very reasonable.
dolutegravir, abacavir 3-TC I'm using less of. I'll tell you why in a moment. Or dolutegravir plus either TAF-FTC, TDF-FTC, or TDF-3-TC. Raltegravir, another integrase inhibitor, is also reasonable. It's got a downside that I'll talk about in a moment, but is a reasonable one. And then what's newest here is the dolutegravir 3-TC, the two-drug therapy, and we will talk about that for in just a moment. Here, the guidelines suggest don't use it in people whose viral load is over 500,000. This patient's viral load was 650,000. Don't use it in hepatitis B because you want two Hep B active drugs. And don't use it when you want to start ART before you get a resistance test back or hepatitis B results. Okay, I promised we'll talk a little bit about dolutegravir 3-TC. This is the newest of the recommended regimens. This is the Gemini trial, which really supported the use of dolutegravir 3-TC in initial therapy. Over 1,500 patients, 1,400 patients got randomized to either two-drug therapy with dolutegravir 3-TC or standard three-drug therapy with dolutegravir, TDF, and FTC. It was mostly males that were in this study, 85%, young people, ages 32 to 33, and the viral load was about 10,000, a little over 10,000, and the CD4 count was pretty high. It was over 460. Only 8% had a low CD4 count. Here is the bottom line results. Three-drug therapy, two-drug therapy, really no difference all the way out to week 96 in terms of viral load suppression. No resistance, and that's really important, no resistance in either arm. And so that was reassuring and supportive of this two-drug therapy. Some experts will be a little cautious about CD4 count less than 200 because only 8% of people had a low CD4 count. In that group, there was a somewhat lower response rate with the two-drug therapy, but it did not seem to be related to virologic failure. So this is my take on two-drug therapy. I think it is a good option, especially for those patients who match the Gemini population. I've mentioned who those are. I've been doing it, using this regimen for people who have a genotype, a surface antigen. I've not been using it for same-day starts because I don't have those back on the same day of a diagnosis. And I didn't show this, but in someone who you've already got suppressed, dolutegravir 3-TC is also a reasonable option to switch people to, and that's based on a different trial called Tango, which supports two-drug therapy, as long as they don't have a history of resistance or treatment failure. And because we have this option, I'm using less abacavir than I was 5 or 6 years ago in that setting. This is how I think about these four combinations that I think we've been talking about. TDF, FTC, dolutegravir has the pro that TDF is actually associated with somewhat lower lipids. Happy to go into that in some more detail. It's a good option for people who are co-infected with Hep B. The main con is that TDF does have somewhat greater impact on the kidneys than abacavir and TAF, and you should avoid it if the creatinine clearance is low. TDF also has somewhat greater impact on lowering bone mineral density than abacavir or TAF, and I do avoid it in people who have osteoporosis. TAF, FTC, dolutegravir, some of you voted for. This also is a good option. It's got more favorable effects on bone and kidney markers. It's 2 pills a day. There are some weight gain issues that we'll touch on, and we've talked briefly about the lipids. Most of you voted for TAF, FTC, bictegravir. This is a single pill combination. There is some data that I'll show you on weight gain with TAF, and there is some data with lipids, but it is a convenient option, 1 pill once a day. And then I think we've covered dolutegravir 3-TC. I'm going to be briefer here. Always check out for drug interactions when you're starting a regimen. This is a useful site from the University of Liverpool that I highly recommend. One drug interaction that's worth mentioning with integrase inhibitors is that you want to stagger your dosing away from iron, calcium, polyvalent cations, because that can interfere with the integrase inhibitor absorption. Are integrase inhibitors perfect for everyone? Well, no. There are some situations where you won't use an integrase inhibitor. I mentioned the drug interactions with integrase inhibitors. A lot of our patients are on metformin, and you want to be cautious about not using too high of a dose of metformin if you're using dolutegravir because of a drug interaction there. Weight gain is associated with integrase inhibitors, as I'll show you. And then in sexually active women of childbearing potential, there are some unique considerations that we'll talk about. Okay, so these are some weight gain data from just about a year ago from South Africa. The point of this slide is that people who got put on an integrase inhibitor, dolutegravir, had greater weight gain than people who were put on efavirenz, which is in green. So the blue and red lines are the integrase inhibitor-based regimens, and the green is efavirenz, and especially in women, over here on your right, quite a bit greater weight gain if they were put on an integrase inhibitor, and particularly if they were also put on TAF. And so that's an important consideration that we're still trying to sort out the mechanism for. These are data from studies done in the United States and Europe, a pooled analysis, and the bottom line from this study is similar. Weight gain was greater in people who got bictegravir or dolutegravir than in people who got elbictegravir, and weight gain was greater in people who got TAF as compared to other nucleosides. So if you remember nothing else, just remember that weight gain is important, of course, and that there may be an impact of some of our regimens, and that's something that we're going to try to sort out in the future as to how we might address or ameliorate the weight gain. Closing in on the last 4 or 5 slides, I'll just mention the pregnancy issue. I want to highlight the new DHHS guidelines that came out also in the last 6 months. For women who are pregnant, and this is the interactive question that we started with, it's recommended that you give abacavir 3-TC or TDF-FTC or TDF-3-TC plus an integrase inhibitor or a protease inhibitor. Dolutegravir in early pregnancy, around the time of conception, there are some data about infant neural tube defects if a woman takes dolutegravir around the time of conception. But a really important point here is that once a woman is past the first trimester, dolutegravir is actually a preferred regimen because it's a very tolerable regimen that has good efficacy and has not been associated with any pregnancy issues once a woman is beyond the first trimester. This is the interactive question. You're going to want to avoid anything that has cobicistat in it during pregnancy. I think the answer that was the one to avoid was atazanavir cobicistat. The reason that you don't want to give cobicistat to a woman who is pregnant is because the levels are too low of the drug. So that's the one that you want to avoid for sure in someone who is pregnant, is a cobicistat boosted regimen. Cobicistat is a pharmacologic booster. I think I've covered a lot of this. If you have a person that you're thinking about starting and they haven't yet conceived but want to, I do have a discussion around this fetal neural tube defect issue. It's at low risk, and an important point to mention here is that we have incomplete data on other antiretrovirals, including other integrase inhibitors, and so that's got to be acknowledged. In a woman who's trying to conceive, I will usually use one of the DHHS recommended options, and they're listed here, with dolutegravir as an alternative. And then for a sexually active woman who's not planning to conceive, I really just go through an informed decision-making process. And I think of bictegravir and dolutegravir similarly. I'm going to skip this slide for the interest of time, and we can certainly come back to TAF if people are interested. There are supportive data that are coming out, haven't been published yet, but are coming out on TAF, showing that it looks like a good option during pregnancy in combination with dolutegravir. And then if you have a person in whom you don't think an integrase inhibitor is optimal, you've got plenty of other options, and some of them are listed here. And I do use these on occasion, although not for the majority of people with newly diagnosed HIV. One slide on monitoring. This is my approach. I'll usually do a viral load monthly until the person is undetectable, and then I'll space that out to every 3 to 6 months. This is your best indicator for your patients and for yourself that the therapy is working. I'll do safety labs, chemistries, BUN, creatinine, and liver enzymes about a month after starting, and then every 3 to 6 months. So CBC and DIF, you don't need to check as often, every 3 to 6 months. Fasting glucose and lipids before you start ART, and then if they're normal, once a year. Urine analysis once a year, a little bit more frequently if they're on TDF. And then here's what's changed in the last few years. CD4 counts used to be done like clockwork every 3 months. Now I think it's clear that the viral load is what you want to focus on. And once you're beyond a year or two of ART and someone is virologically suppressed, then you can really drop doing the CD4 count, space them out, or certainly consider dropping them if the CD4 count is high. One of the questions we got in advance was on where do we think we will be in the future. Injectables, I hope, are coming. There is good data for this particular combination of monthly cabotegravir injected with rilpivirine. Cabotegravir is an integrase inhibitor. Rilpivirine is an NNRTI. And there are good phase 3 trials supporting this given monthly, as well as trials really showing that maybe it could be even given every 2 months. And we can come back to this. It's not yet approved, so I won't dwell on it now. But something for your patients who are struggling with adherence. Once they're suppressed, we might have options in the future for injectable ART, either once a month or every 2 months. And maybe we'll do a session review on that once they're available on a future IAS-USA call. Okay, so let's wrap up. So there's time for questions. Going back to our patient, he's 45, he's got HIV, he's got GERD, allergic rhinitis, hypertension, and smoker, a lot of cardiovascular risk factors. He's on omeprazole and fluticasone. Those particular drugs interact with several of the commonly used regimens, but not with integrase inhibitors. The CD4 count is over 500, the viral load is over 500,000, and he's got no resistance. OI prophylaxis, don't need to worry about it. His CD4 count is well over 200, not indicated. In terms of what I would start him on, fluticasone is one of those drugs that can interact with protease inhibitors and cobicistat. That's why I would choose a non-protease inhibitor regimen. I would avoid the drug TDF in him because he's got some renal insufficiency. TAF is okay. And his viral load is over 500,000. I think most of you didn't want to use 2-drug therapy. I would agree with you. That's not the Gemini population. So what we did in this man is we initiated TAF FTC plus dolutegravir, one of the 2 favorite choices. We monitored his viral load monthly until he was undetectable. That's the best indicator that ART is working. And then we did it every 3 to 6 months, and we space it out even further at times if the person is durably suppressed. And then we monitor his safety labs, his kidney function, liver enzymes, CBC, and also can space those out once they're suppressed. So I think we have a good 25 minutes or so for questions. I want to thank you for your attention, and happy to, along with Dr. Saag, take comments and questions and go from there. Let's put our videos back on. I think I'll stay on the video. You see Dr. Saag back, and pick it up from here. Mike, do you want to?
Yeah, let's do the post-test. We've asked this question. I think this is the 47th time for this question, so we'll just quickly answer, and maybe we'll get 100%. Looks like we are. Fantastic. It looks like it's coming in. Oh, well, there's a few. That's okay. Let's go ahead and publish the results. Great. So 4 people still like it as number 5, but it's number 1 is the answer. And then moving on to Dr. Gandhi's question, a woman in her 30s, second trimester. Let's go ahead and vote. Yeah. I think people were listening very carefully as you guys can't see the votes coming in, but it looks like a lot of people. Some folks are thinking a little bit about it.
We'll probably publish it and see.
Yeah, let's go and see what we got.
Yep. Yeah, here's the one where you want to avoid the cobicistat because you just don't get enough levels, high enough levels. Dolutegravir, once you're in the second trimester, is okay. That's a preferred regimen. It's really around the time of conception that we have those conversations about the neural tube defects. But cobicistat is what I would steer away from in the second trimester.
You know, it's interesting, isn't it, that back about, 2000 or so, the exact same issue came up with efavirenz, remember, and it was the neural tube defects, and initially there was a wide gap in the number of children born efavirenz with neural tube defects, and as we got more data narrowed down, the same thing's happening here. So it is probably a little bit higher risk, but it's not a substantially higher risk than just the natural evolution of that. So time for the questions and answers, and maybe, Raj, if it's okay, we just kind of alternate with each other. I'll read a question that's more to the first talk, and then you can read one that's to yours, and we'll just keep going till we run out of time or run out of questions. So let's see. It's being cut off. Oh, there we go. So what determines why specific cells become latently infected as opposed to just killed off? And the answer is, don't know. I think my best guess, and I'm curious to hear what Dr. Gandhi says, is that the thing that allows a cell to persist while it's infected is probably a number of things, but as much as anything, it could be the recognition of that cell as foreign and being killed off by the immune system, and that, I think, explains why this host-virus relationship exists. Think of it, the immune system can tolerate so many cells that are infected, and then it kills them off. And some of them just are able to escape immune surveillance and be able to exist for a period of time. There may be other reasons that the virus integrates into a spot where it doesn't produce virus very actively, but those would be my guesses. What do you think, Raj?
Yeah, no, I think that's right. The as Dr. Saag mentioned, the activated cells are the ones that are kind of vulnerable, so it's probably a cell that gets activated and then gets infected and maybe then gets to that back to that resting state before it gets eliminated.
Yeah.
People have tried to figure out if it's HIV-specific cells or CMV cells. A lot of us have CMV-specific cells, EBV. I think it's probably fairly distributed among all different types of T cells. It just so happens which one gets back to that resting state and then goes into hiding. Once you are resting, the cell HIV doesn't get transcribed, and then it becomes kind of hidden to the immune system, and it just persists. So, yeah.
Okay. So you want to take one there?
Sure. There's a lot of questions around the injectables. I think that's something we're all interested in. There's not one person asked if there's an injectable version of TAF, and that's not yet available, or there's not an injectable version of that. The ones that are closest to the clinic is the integrase inhibitor cabotegravir, which is kind of like dolutegravir, chemically a little different, but it's also an integrase inhibitor, and then rilpivirine, which is the non-nucleoside RT inhibitor. Those can be formulated as nano formulations that can last for a month or more. Actually, they last even longer than a month. And so I will say, I didn't put this in my slide, but our neighbor to the north, Canada, has actually approved cabotegravir rilpivirine. But here in the United States, the FDA wanted some more information about the manufacturing of the drugs. And so I don't know precisely when it might be available in the U.S. I would hazard to think maybe this year they'll visit that in terms of its approval, but not available in the U.S. yet. You can go to Canada.
Okay. Here's a question. Yeah, here's a question. Can a blip produce enough infected cells to allow transmission to occur? So usually a blip is that little activation of cells where you can detect virus, and that, as we mentioned, the viral load usually creeps up to, I don't know, pick a number, 50, 75, maybe 100, usually less than 200. And so the question is, we know that antiretroviral therapy, when people have suppressed virus and it's sustained, they're not infecting other people. So that's a second benefit, not only prolonged survival, but also reduction of transmission. The cut point for when the viral load is transmissible is mostly a function of the viral load, and to my knowledge, I've not seen any evidence that there's any transmission when the viral load is below 500 or certainly below 200. There was a study out of Africa way back when with Tom Quinn and Rakai, and he had quintiles of viral load and showed that those individuals followed over time, obviously before there's antiretroviral therapy, that they were in the quintile with less than 1,000 copies. They typically did not transmit to their partners. So I don't think a blip is likely to be responsible for any transmission.
I'm seeing a couple of questions on resistance testing, so maybe I'll take two questions and put them together. So the first question is, why is the genotypic resistance test more important than the phenotypic? Probably wouldn't say that it's more important, but we use it earlier on because for most people with newly diagnosed HIV, the genotype tells you the information you want to know. Are there mutations that would impact the ability of a regimen to work? And you don't necessarily need the added complexity or expense of the phenotype in people who have newly diagnosed HIV. I reserve the phenotype for people in whom I'm trying to figure out, are there mutations interacting with each other, or is one mutation offsetting another or augmenting another? When the genotype's complicated, then a phenotype gets you that extra bit of information. So genotype is a good thing to do early on because it gives you the clinical information you want to know. In a person who has not taken medicines for a period of time, when should you do a resistance test? That's a very good question. And what it's alluding to is the resistance test can tell you one of two things. If you do a genotype in someone who's never been on a med before, what you're looking for is transmitted drug resistance. That is resistance that came from the person that they got the virus from. That's called transmitted drug resistance. And in the United States, about 15% of people with newly diagnosed HIV will have a resistance mutation that's transmitted from someone else. In someone who is on ARVs themselves and gets resistance, what happens is when you stop the medicines, that resistance can fade. If that virus that is resistant is kind of not very fit, it gets outgrown by so-called wild type or fitter virus. And so the best time to do a resistance test in someone who's not been on meds is before they start, see if they've got transmitted drug resistance. And then if they're on a med and they're not suppressed, you want to try to do that resistance test while they're on the medicine so you can pick up the selection of the resistant virus. If they've stopped the medicine, say they stopped it without telling you and they've been off it for a year, I would still do a resistance test before restarting, but I would keep in my mind that I might be missing some resistance that they used to have that got outgrown by the fitter virus. And I sometimes keep that in mind as I'm designing a second regimen. So, yeah, it's a good question.
So I have a question that I think is really important about, it basically says at some point the one-to-one law of virus to cell of the relationship is going to break apart because the CD4 counts get very low. And in truth, what's happening in the peripheral blood is not what really I'm referring to. The CD4 count that you detect is drawn from the bloodstream. And inside the lymph nodes, which is where all the action is, that's where all the transmission's happening from cell to cell. That's where it matters, and that's where the relationship is. So the actual, you can have a CD4 count of 2, and that doesn't mean there's only 2 cells in the body that are left. It's just that the majority of those cells are likely, a lot of them are trapped inside lymphatic tissue because of activation. Yes, the overall total number of cells has been reduced, and you know that because the actual white count, if you will, is dropping, the percent total lymphocytes is dropped, but there's still plenty of CD4 cells there, and the majority of them, again, are still unactivated, so it's really only those activated cells. And another corollary of this is that people say, well, where does HIV replication take place? A lot of people think in the bloodstream. That's really not the case. You think about the blood traveling around at 5 liters per minute. They barely have time to say hello to one another when they pass by. It's like, whew. And where they congregate is in lymphatic tissue, and that could be in the gut, it can be in the spleen, the lymph nodes, etc. And that's where replication happens. So when I'm talking about that one-to-one relationship, that's inside those lymphoid tissues.
There's a couple of questions about weight gain and one on osteoporosis, and maybe I'll tackle those together. So, Dr. Saag and I have been around long enough to know back in the 80s and 90s, weight gain and bone density were not our primary concern, and now they really are, because as people are living longer with HIV, weight and bone health are coming to the fore because we're talking about decades, not years or months. So weight gain. A person is asking, what is the mechanism of the weight gain with integration inhibitors and with TAP? I wish we knew. We just don't know yet. What I can say is, irrespective of the drugs you start, everybody gains some weight when you start antiretroviral therapy. That's probably good. That's probably the return to health as the kind of the metabolic causes of having uncontrolled viremia, those billions of viruses that Dr. Saag was talking about, that takes a metabolic cost on people. And when you get rid of that virus, get them down to undetectable, then people will gain weight. That's normal. But there are these, maybe about 10% of people, they'll gain much more weight than one would expect. And those are the people we're trying to sort out why it's associated with certain factors. Low CD4 count is one of them. Sex is one of them. Women tend to gain more weight after starting antiretrovirals than men. And African Americans tend to gain more weight than non-African Americans. As to the mechanism, we don't know. There is this link between integrase inhibitors and with TAF. Some people wonder if it has to do with fewer side effects, less of an effect on appetite. But honestly, we don't know. And the other clinical issues, we don't know whether switching them off of TAF or switching them off of an integrase inhibitor will kind of cause them to lose weight. There is a AIDS clinical trials group study being planned to try to answer that question. And so for now, I counsel people, but I have not been preemptively switching them because we just don't know if that will help. The bone density, I'll finish up with that. People outside of in primary care will use something called the FRAX as to decide when to do a DEXA scan. FRAX is kind of a score that you can use to think about when to do a DEXA scan. Some people think that the FRAX score underestimates osteoporosis in HIV. Some experts will start doing a DEXA scan in postmenopausal women with HIV or men over the age of 50. That's based on expert opinion, but it's based on the fact that there are greater rates of osteoporosis in people with HIV. We also know that people with HIV have a higher rate of smoking, and that's probably a contributor as well. But age 50 and above, a lot of us will start talking about doing a DEXA.
So as far as the weight gain goes, I've noticed ever since I've been writing for antiretroviral therapy, my weight has increased, so be careful out there. When someone has been taking ARVs and stops them, how frequently are symptoms like acute syndrome going to recur? And that does happen. It's in a few patients. It's not that common, but usually it's somebody who has had the original acute infection. You treat them early like we really want to do. We didn't talk about that, but you really want to start therapy. Somebody comes in with acute seroconversion syndrome, you want to treat them right now and get that viral load down before it can do as much damage once it really takes root. But the cases that I've seen of this rebound phenomena when you stop the antiretroviral therapy and symptoms of acute syndrome come back is often in people who were treated very early and then they basically pick up where they left off. It can also happen with others, but that's a good question. And then the other question here is when someone stops antiretroviral therapy, which number changes, which changes first, the viral load or CD4 count? Viral load is the first thing to really come back, and you see it starting to rise. That's your best thing to follow over time. A lot of the guidelines now have mentioned, especially IAS-USA guidelines from last generation, said once the CD4 count, as you heard, is above 200 to above 350 and it's above there and the viral load suppressed, you don't need to keep checking. But if the viral load comes back up, they're failing, the regimen's failing, then you want to start re-engaging with CD4 counts at that time.
A couple of people are pushing on the differences between the integrase inhibitors. How does one decide or querying about that? So I think that's a great question. How do you decide between, let's say, raltegravir, bictegravir, and dolutegravir? Depends a little bit on the particulars of the person. So bictegravir's advantages, it's in a single pill combination with TAF and FTC. So if pill burden is a particularly major issue, then that's a place where you think about bictegravir. The downside of bictegravir is twofold. One is in someone who is on a rifampin-containing regimen, either they have TB or they have a staph infection for which, a Staph aureus infection for which you want to give rifampin. Bictegravir really does not play well with rifampin. It just interacts too much with rifampin, and you really can't overcome that with dosing adjustments. So that's a place to avoid bictegravir. We already talked a little bit about women who are trying to conceive in terms of we just don't have much information about bictegravir in that setting. When do I use dolutegravir? Dolutegravir is once a day. You can dose it with rifampin. You have to make some adjustments in the dosing. You have to do it twice a day, but it can be given with rifampin. And we know a fair amount about it in terms of pregnancy, as I've alluded to. The time that I would probably steer away from dolutegravir is if someone is on a high dose of metformin. You don't want to be more than a gram of metformin and give dolutegravir. There is an interaction there. Up to a gram of metformin is fine, but once you get beyond that, then the interaction becomes problematic. Raltegravir, we spend the least time on raltegravir. Raltegravir's got a greater pill burden. It's 2 pills a day. It's either 1 pill twice a day or 2 pills at once. There's 2 different formulations of raltegravir. The times I think about raltegravir is in a woman who's trying to conceive. We have a fair amount of data on raltegravir's safety in that setting. Not perfect data. Nothing's perfect, but we have more data than we do for some of the other integrase inhibitors. And that's a time that I might think about raltegravir is in a woman who's really trying to get pregnant, and you want to have a regimen that we have a reasonable amount of assurance in. So that's a little bit about those 3 integrase inhibitors. Elbitergovir, Cobi, just to finish off, that I generally have been using less and less because it's got that booster in it, the cobicistat, and that can cause drug interactions with fluticasone, a commonly used inhaled steroid, as well as with certain statins. So.
Okay. Here's a question about why is it that some patients are undetectable but their CD4 counts don't rise? We alluded to that a little bit earlier, but to dig a little deeper, there are people who do not get that initial release of redistribution. Think almost like you do when you give steroids to a patient and they get demargination, we used to call it, of white cells into the circulation. You get that bump. The same kind of thing is happening inside the lymphatic tissue. When HIV is replicating in that very high level like we talked about, it stimulates elaboration of adhesion molecules called ICAM and VCAM, and they trap cells in the lymphoid tissue. When you stop the replication, those adhesion molecules reduce dramatically, and the cells are released back into the circulation where you can detect them. Some people, for whatever reason, and I don't know the reason completely, have kind of burned through their lymphatic tissue to where there's not many being trapped. And so when you stop the replication, there just aren't cells to be re-released, and you don't get that bump. And then you're left with the slow rise of CD4. That is a biologic phenomena of the cells kind of coming back. There were studies in the early to mid-90s in people with rheumatoid arthritis where they gave, in essence, an anti-CD4 antibody, and you initially saw the CD4 drop, and then it came back. But if you got 2 to 3 or 4 doses of that, the CD4 count went down and just really took a long time to go back, as if you destroyed a lot of them, and now you're just waiting for the natural replenishing of CD4 cells to happen. And I think that's what's happening in some patients who have lost their lymphoid architecture.
A question that comes up all the time from my patients is one that is put here, which is if a person needs to be switched from one ART regimen to the next because of an adverse event, is there a significant risk of developing resistance? So if that person is suppressed, viral load is less than 50 or less than 200, and you're switching them, as long as they keep taking the new regimen, there's really no risk of resistance. It's only when you get viral replication in the presence of inadequate levels of drugs that you can get resistance that selects for it. So I reassure my patients, if I'm switching them because their kidney function has changed, or they're having nausea, or they're having, they want to change to a different regimen to be more convenient, they're not burning through any med. They can always go back to the med that you switch from because they would not be resistant to it. It's really only if you have incomplete adherence or viral replication. It's not due to switching if they're suppressed. And I hope that answers the question. So, yeah.
Okay. There's a question here about treating some patients whose viral load would just slowly increase over time. And the question is, why was that happening? But then when they checked them, they saw that resistance to ARV had happened. And so what that is a good point about, as opposed to a blip where the biology we've talked about a lot where cells just kind of release and then it goes back. When there's resistance, and that's usually from inadherence, if you see somebody whose viral load has gone above 200 and you recheck them kind of quickly as recommended and it's rising further, if you were not to change the regimen and allow them to have that replication continue under the pressure of antiretroviral therapy, resistance is going to emerge. It's like most other bacteria that we've seen or other viruses, that if you allow replication to occur with partial reduction, with incomplete suppression of replication, the virus will figure out a way to let those mutations that happen start to lead the way in terms of the most predominant virus. And it's basically like evolution, right? You get survival of the fittest in that setting where the drugs are on board. So if you start to see that happening, it's really important just to pause. First time you see the viral load go up, you want to have a discussion about adherence, try to fix it as best you can. Sometimes you'll discover that the medicine's making them sick and they feel bad, and I don't want to take a medicine that makes me feel bad, so try to find another regimen. Fortunately, we have a lot of choices. And one person asked a little while ago, why do we prefer integrase inhibitors a little bit over PIs, and partly it's about tolerability. The tolerability of the integrase inhibitor regimens are just really pretty remarkable, and the PIs, because they require boosting, either the kilbastistat or the ritonavir can be associated with some side effects that kind of makes it harder for those drugs, not to mention the drug interactions you just heard from Dr. Gandhi. It also, there's a little bit more nausea, a little bit more of a diarrhea, and if that's bothering people, they're just not going to take the medicine, and that can lead to resistance. Have time for about one or two more questions, and we're going to have to wrap up.
A couple of people are asking about hepatitis B. That's a really good question and probably deserves an hour of its own. I'll be brief here. I think what I do with hepatitis B is the following. If they have chronic hep B, of course, you're going to want to have them on 2 drugs, tenofovir plus 3-TC or FTC. In terms of monitoring someone who is not hepatitis B infected, how often should you check their hepatitis B testing to see if they might have acquired it? I'll say 2 things. One is if you're on tenofovir, it's pretty rare to acquire hepatitis B. Now that the person asking that question totally knows that because they made the same comment. As we move away, as we sometimes use dolutegravir 3-TC or non-tenofovir containing regimens, that really is a highlight to get our patients immunized and get them protected that way from getting hepatitis B. Once they're surface antibody positive, then you can rest assured that they should be protected. Now, not everyone gets a response to hepatitis B vaccine. There's a somewhat newer adjuvanted hepatitis B vaccine with the CpG island. It's called Heplisav. And so people are now studying that to see how that behaves in people with HIV, to see if we can get some people who couldn't convert with the older hepatitis B vaccines to be surface antibody positive. And so that getting them immunized is key. And if they're not able to be immunized, if they don't seroconvert, then it depends on if they have an exposure. If they have an exposure, then I would recheck their hepatitis B, but I haven't been doing it routinely. So I think we're right at the hour, half hour.
Yeah.
Mike, you want the last word?
Yeah, I'll take the well, maybe we'll share this answer because I'm not sure I can answer it fully. It's a good question. And the question's about the conversion from CCR5. Remember, I mentioned that co-receptor that's right next to the CD4 molecule, and it is a co-receptor that's required for entry. And so it can either be a CCR5 co-receptor or a CXCR4. And usually the initial infection almost always goes through the CCR5. But over time, we've noticed that there tends to be a transition, especially as patients have had the infection a long time, not treated. Then it goes to more of a CXCR4 pathway. And the question is, why does that happen? The reason it's important clinically, because there is a drug called Maraviroc that specifically blocks CCR5, but late in the course of infection with more CXCR4 usage, that drug doesn't work in that particular setting very well. So the question is, why does that transition happen? And my answer is, I don't really know. I think it's obviously a phenomenon we see, but I don't know that I can explain why that happens, but it does seem to happen. Dr. Gandhi, I don't know if you have want to take a stab at that.
I think it's a great question. I don't know if there's some immune surveillance that as the body's immune system gets weaker, then those X4 utilizing viruses just have the kind of the wherewithal to grow out. But it's a good question. No matter how many years we've been doing this, there's still questions that we still don't know the answer to.
Yeah, and that's why I'm happy ending with that question, because it appears, especially people new to the field, you're coming in and you think, oh, we got all the answers now. No, we don't. And we're going to always be learning, and we're always thinking, and there's always more that we can use to finesse our improvement of care, we have come a dramatically long way. We've really had remarkable progress in this field, and you're coming into it at a time where you really can make a difference for patients in a very real way. So it's an exciting time, but there still are unanswered questions. So that's why I thought I'd be good to end with that. Just to also kind of wrap up, reminding you that evaluations and information on how to claim the CME for any of the disciplines mentioned there will be emailed by 5 p.m. Pacific time tomorrow. If you're not receiving emails from IAS-USA, check the frequently asked questions on the website, IAS-USA.org. There's some upcoming events that might be worth tuning in, assuming you have a little bit more time today. There's a COVID discussion on health disparities between some of our Emory colleagues, Wendy Armstrong and Carlos Torrio, that should be really good. And then some updates from the brother and sister team of Drs. Gandhi that will be coming from the IAS meeting. Monica is one of the co-chairs of the meeting, and that'll be really important. On July 22nd, then I'm back with Dr. Schooley to talk about COVID in an open discussion, and then there's another like a redo of a discussion between Paul Volberding and George Rutherford at UCSF on COVID. So we're talking a lot about COVID. Reminder, this is the International Antiviral Society USA, so COVID fits into the mission. Coming up, there's going to be a CME update. We usually had this meeting in New York and Atlanta. We've combined it, as well as the Washington, D.C. meeting. So that's going to be on July 14th. Great lineup. You can check it out on the website. And then for the Midwest, it's just more of a tradition of where these meetings originally occurred. There are different speakers that are mostly coming from these areas, not exclusively, but that one's going to be on July 30th, so you can check out the agendas on the IAS-USA website and see which ones you want to join. And then there's additional webinars. We've already talked about weight gain